So thank you to the LSRS for the opportunity to present. We're going to talk about strategies for success with MIS in early practice. So I'm at WashU in the ortho department. I'm just finishing up my third year of practice. This is my only disclosure of Globus, which is relevant. Another disclosure is that this is only my perspective and is heavily influenced by my training and practice, and others' experiences will differ and are equally valuable. So clearly very colored by my training and my current practice, and everyone will have different experiences. So MIS has moved from a niche skill set to an expected component of modern spine care. And I have these images here. When I'm talking about MIS, we're talking about endoscopy, tubular surgery. But I think that there are concepts here which are applicable to really both types or any type of minimally invasive spine surgery. So for many of us in early practice, the question isn't whether to do MIS, it's how much, how fast, and how safely to incorporate it. So for this talk, we'll focus on practical strategies, how to adopt MIS thoughtfully, how to avoid common pitfalls, and how to build a durable, efficient practice, even if your fellowship or training exposure was limited. So first point we'll make is to be selective early and to match the case complexity to your skill curve. The second point will be to build a reproducible system, not just a skill set. Third, to know the pitfalls and respect them. And fourth, if you didn't train heavily in MIS, you can still build it. So for the first takeaway, be selective early, match case complexity to your skill curve. I think it's important just to keep in mind that the patient outcome is priority number one. And early MIS experience should be defined by appropriate restraints. I like what Dr. Sansone said earlier about responsibly pushing your limits. And this will look different for different surgeons depending on their training. So one example may be starting with 1 and 2 level decompressions, tubular microdiscectomies or endoscopic microdiscectomies, MIS laminectomy for straightforward stenosis. Consider delaying more complex cases like multi-level MIS decompressions, complex deformity or revision cases, or MIS TLIF and challenging anatomy until you're more comfortable and facile with the techniques. These are just a couple cases from my first 6 months of practice. This was a 60-year-old male with right L4 and L5 radiculopathy, L4-5 disc collapse, and asymmetric collapse on the AP there. Has severe right foraminal and lateral recess stenosis corresponding with his symptoms. I did an MIS TLIF on this patient. He's currently 2 years post-op, and his pre-op symptoms are gone, and he's doing well. Next is a 77-year-old female with back pain and neurogenic claudication, very active, had failed all non-operative treatments, has severe disc and asymmetric disc collapse at L2-3, and severe stenosis at that level. And calcified disc at that level. So I treated her with L1 level L2-3 prone lateral fusion, and I also did a direct decompression given the calcified stenosis. She's 1 year post-op, or she's over a year post-op. Those are her 1 year post-op x-rays, doing well. So these are kind of simple cases that I think are appropriate when you're still learning quite a bit. The second takeaway is to build a reproducible system and not just a skill set. So this is an image from AO about one way to arrange your OR for prone lateral fusion. So this can include OR setup standardization, the table, fluoro positioning, instruments, and equipment consistency, and then also team familiarity. So different practice setups will be more conducive to this, but if you're able to get reliable scrub techs, circulating nurses, anesthesia, radiology techs, and then industry representation in your OR, I think that can be very helpful with these types of surgeries. The third takeaway is to know the pitfalls and respect them. So I think some common early pitfalls for MIS surgery are inadequate decompression, radiation overuse and inefficiency, and prolonged OR time, which can impact outcomes and team buy-in. So this is a 48-year-old female who presented with acute cauda equina syndrome and left lower extremity radiculopathy secondary to very large L4-5 and L5S1 disc herniations. This was 3 months into my practice. At that time, I wanted to do everything that I absolutely could to just make sure that she was completely decompressed. So I did this, what quote unquote open. This was an L4-5 and L5S1 laminectomy with microdiscectomy. She is thankfully neurologically intact now and regained all of her function. At the time, that was what I felt was the safest and most reliable way to treat this woman. Recognize the pitfalls. So this is a 71-year-old female attorney who presented to me with neurogenic claudication and left lower extremity L5 and S1 radiculopathy. And there's some characteristics on this MRI that tell me that this is going to be a very challenging decompression. There's massive facet hypertrophy, and this is someone who, if performed in an MIS fashion, has to be done very thoughtfully and very meticulously. We did a two-level tubular decompression on her, and she has done very well. We got a post-op MRI. She has a L1 lesion, so for surveillance of that lesion, but her symptoms are completely gone and were gone immediately. She went home post-op day 0. But I think really studying the imaging and knowing features that can be challenging is also very important. This was a 61-year-old male with low back pain, neurogenic claudication, and stenosis at multiple levels. He presented to me very early in my practice. I treated him with a staged procedure, L5S1 ALIF, and then an open L2 and S1 to pelvis fusion. At the time, I was really not doing lateral surgery, so this was just the most efficient way to treat this patient in my hands. He's over a year out now, and he's doing well. But since then, I've transitioned to doing more comparable cases, all MIS. So this is a 71-year-old female with grade 2 isthmic 5-1 spondy and degen flatback. We did this surgery all MIS, L5S1 ALIF, and then 2-level prone lateral and fusion L3 to the pelvis. She's now 3 months post-op and is doing very well. This is another case, and also a 71-year-old female with scoliosis above a prior L4 to S1 fusion. We treated her with the all MIS approach, L1 to pelvis fusion with 2 prone laterals, and she's also doing well. The final takeaway is that if you didn't train heavily in MIS, you can still build it. So I think for those of you who are still in residency or fellowship, the goal should be to develop a solid foundation during training and to seek out opportunities to learn anatomy. So I thought that in my training, these were big open cases and involved freehand instrumentation. So some practical strategies are starting with techniques adjacent to what you already do. So for me, this was learning prone lateral surgery. I did minimal lateral surgery in my training, something that I've been able to pick up in practice. Use industry and cadaver labs strategically. Observe peers or invite mentors or colleagues into your OR. And then finally, gradually expand indications as you become more facile. And I think regardless of training exposure, seek out ways to get better. So I'm fortunate to be at WashU, where I have Zach Ray, who's a real pioneer in MIS TLIF surgery. And I did a lot of MIS TLIF in my fellowship, but there were some interesting components of the procedure that Dr. Ray does that I was not exposed to before. So these are contralateral facet work in the use of articulating table. So these are some images intraoperatively from one of Dr. Ray's cases showing the use of articulating table to really maximize the cage expansion and lordosis. This is a case where I use these techniques in a 64-year-old lady with severe 4-5 disc collapse. And I think just trying to always get better regardless of your training is also important. Bottom line, MIS is not all or nothing. Key takeaways are to be selective early, protect your outcomes, build a system, respect the pitfalls, and you can grow into MIS deliberately. This is a picture from my OR during my first prone lateral surgery. We have Dan Hafez is one of my colleagues who's really an expert in prone lateral, and then Dr. Ray also giving some of his technical feedback in that case. Thanks very much.